Well, hello and welcome to my wound care channel. My name is Doug. The purpose of the wound care channel is to educate people who are taking care of loved ones at home with wounds. Could be any kind of wound, pressure ulcers, diabetic ulcers, whatever. And it's just, you find yourself in a situation where you're having a difficult time getting to see a physician or getting follow-up visits to see a physician or a podiatrist or physician assistant, nurse practitioner, whomever it might be. And these days it's just getting more and more difficult to get in to see a primary care physician, certainly initially, and then for follow-up visits. I don't know what part of the country or world you might be in, but where I'm at, that is a concern. There's no ifs, ands, or buts about it. And certainly with a diabetic ulcer, a week or two can make a huge amount of difference in the health of the individual and where exactly the wound is at. So I think I just wanted to get this wound care channel going so that I could educate folks that find themselves in that position to help them, do their very best to keep the wound from worsening. A lot of wounds can be very life-threatening, and we certainly don't want, to see people suffer. And so that's what the point of this wound care channel is. It's not about trying to replace your physician. The caveat would be, hey, look, I'm just on the other side of a TV screen here, and I'm talking to you. You might be in your living room or in your car or wherever it is that you are, and you have this, it's like, what am I doing? What am I going to do for my loved one? What am I doing with this wound? How am I going to take care of it? And that's what this is about. It's filling that void. It's not about filling the void of you actually getting in to see your physician or a primary care individual, or have the patient get in to see the primary care person, their primary care physician or nurse practitioner, PA or podiatrist. It's not about trying to take that away. I can't overemphasize the importance of having an individual's wound actually looked at by the primary care person in person, because there's so much that goes on with the wound bed. You're looking at the wound bed. You can't look at a wound bed over a computer screen or over a television screen and pick up the nuance. How much granular tissue is in there, how much yellow or brown or dark non-viable tissue is in that wound bed. What does it smell like? What does the wound perimeter look like? Is there edema at the wound? These are all things that require a good evaluation, hands-on evaluation by somebody who knows their way around wounds, or at least a physician, to assess the wound and assess whether or not it needs any antibiotics or some kind of maybe some studies done. So we're going to get into the studies. We're going to get into all sorts of things in this wound care channel. How to clean a wound, and of course, when you're going to clean wounds, it's super important that you prepare the location where you're doing your wound care. So for me, in my environment, where I'm at is in a wound care clinic where I work daily. I'm constantly cleaning with a cloth that pretty much kills anything on contact, and I clean my instruments all of the time, or I get new instruments or whatever it is. Things are changing. I'm breaking up the pathway that bacteria can travel. Bacteria can travel like on a doorknob, for example. You might have bacteria on a doorknob, and you might have 10 people in your home. Well, good God, what is that? What's going on with that bacteria? It's getting spread all over the house, getting spread all over the people. Tenfold, and it's wherever those 10 people might have gone and touched, it's going to be put on those surfaces, and that's why it's so important during flu season, obviously, to clean those surfaces frequently. But that's another story. But as far as wound care goes, or preparing for wound care, you want to clean your site, and you can use antimicrobial soaps. There's a lot of different things on the market that kill bacteria on surfaces, and you probably want to look at getting those that can kill COVID or flu or anything else, because they're going to be pretty much probably enough to kill most Staphylococcus, Streptococcus, Enterobacter, just different kinds of bacteria that we find in wounds on a regular basis. Want to find something that's going to be able to kill those items or kill those bacteria. So again, you want to create a nice clean wound environment, or not a wound environment, but a nice clean area to work on your wound. And that means, any cups, any bowls, any toothbrushes, combs, brushes, shoes, things like that. Get those out of your area that you intend to do the wound care at. You want to create as clean a surface as possible wherever that might be. It may be in a bed, it could be in a wheelchair, it could be in a sofa. There's a lot of places in the home where you might feel more comfortable doing wound care. And it might be the place where your loved one is actually stationed. They may be on the couch or in the bed or in a wheelchair or in a chair of some kind. Maybe they're not very mobile at all. Maybe you're going to do some cleaning in your bathroom. Well, you need to clean that bathroom. There's a lot of stuff that goes on in bathrooms that spread bacteria. So everything needs to be very, very clean. And you can use bleach as well and bleach your area. And you can study that a little bit further to find out, how much contact time you might need with the bleach on certain surfaces and what percentages you might need to clean a surface very well. And I'm sure that's available on the internet. I'll be going over things of that nature in the future, like Dakin's solution, for example, but that's for another day. So again, we want to make sure that our patient is comfortable, and we've done the very best we can to remove any items that may create some cross-contamination to the wound. The next thing is the provider, the care provider, whoever that is, needs to wash their hands, right? And we're doing clean techniques, so we want to eliminate any potential for any transmission of bacteria, but we have to recognize the facts that you're doing what's called clean technique. So you're not doing a surgical operation. You're dealing with a wound that's probably got already a significant amount of bacteria in it, and you're just trying not to worsen the situation. You don't want to bring any new bacteria to the environment. And let's be frank, we have bacteria all over our skin all of the time. So if we have an eruption or a tear or we have a new wound, we're going to have bacteria in our wound. We're not going to be able to kill all the bacteria in the wound. If you did, probably the wound wouldn't close. It would be so bad it would cause damage to the healing tissue within the wound bed itself. So you want to wash your hands. And you're going to get some running water, you get some antibacterial soap, something along those lines, and the water's running in the sink, and you're just washing your hands. And you're going to get a good lather going up on your hands, bubbles and all this, because that's going to help lift the bacteria off of your fingers. In surgery, the physicians will get a little brush out, and they're using Hibiclens. I think that's chlorhexidrine. It's a hardy cleanser. I mean, it's going to kill everything, right? And that's for surgery though, right? But they're getting in there and they're cleaning in the nails and around the nails as much as possible to remove and slough off that bacteria that might be on their hands. Then they have, they dry their hands well, right? And then sometimes they'll even have people help them get their gloves on. So there's really not a lot of contamination of the gloves when they reach the patient. And so that's kind of what you want to bring to bear. The rule of thumb for washing the hands is singing the ABCs. And so whatever country you're in, you might want to add a couple of extra, it's like 30 seconds, let's say, right? And a slow 30 seconds. You can hum, you can sing, whatever you want to do to make sure you're making it a period of time. And it allows, time for the antimicrobial soap to kill whatever bacteria you might have. And a lot of these antimicrobial soaps they basically have alcohol in them. And alcohol is a desiccant. So basically what it does with the cell of the bacteria is it dries it out and kills it that way. But again, you want to move it off too. So you move it off through the cleansing process and then again with your drying process. And on a microscopic level, you're always going to leave something behind. There's no ifs, ands, or buts about it. So then we want to get our area that we're going to work in it clean once more. We're going to create a clean field. But let's just go back one step and let's talk about why are we doing the wound care in the first place? Why are we concerned about cleaning the wound? And so, optimally, you're not going to be cleaning a wound every day. We don't want you to clean a wound every day. In my practice, I clean, it depends on the amount of drainage, and that's a whole other video, but I try to clean a wound twice a week. And the reason for that is that every time that you open up a wound and you go after cleaning that wound, you're cooling the wound down. And we'll talk about that later in the video a little bit more, but you're cooling that wound down sufficient such that you're not going to get some good capillary buildup in that wound bed. It's going to sort of want to retract it. It's just like if we were out, in a blizzard, we wouldn't want our hands just out in the open. We'd want gloves, or we'd stick them in our pockets because that just doesn't feel right. And it's the same thing for a wound. If we, unpack a wound, daily, sometimes people will say, hey, you got to, you'll have instructions that they're supposed to clean that wound twice a day. And so when they come and see me, and I go, no, we're going to do that once every, we're going to clean the wound twice a week. And of course, we select bandages that can tolerate the level of drainage. So if the wound drains a lot, if you're at home and you've got a wound and it's just dripping all of the time, first of all, that's a problem. That could suggest maybe there's some form of infection going on, right? So certainly you want to go get some help with that. It could also be that you have a venous insufficient wound where it needs compression therapy, and you might want to go get some professional help for some compression therapy for that wound. But most wounds fall into the category of moderate drainage, over a 2 or 3 day period. And with that, you can use certain bandages to where you're not having to open that wound up every day. But that's sort of an aside. We'll get into different bandages and stuff like that going forward. But the primary reason we're wanting to clean wounds, obviously, is to remove dead stuff out of that wound bed. So we want to clean that wound bed. We're going to use surfactants, a lot of different types of wound cleansing agents out there. There's kinds that have normal saline that's pressurized that you can squirt into the wound bed. There's surfactants that lift stuff up. We want to clean that wound bed, and we want to get dead, non-viable tissue out of that wound bed. That's the number one reason. That stuff sits in that wound bed. It starts to stink over a period of time. We don't want a stinky wound, and we don't want a wound that's got a bunch of bacteria in it that's causing, that's basically feeding bacteria inside that wound bed. So that what ends up happening is that the bacteria themselves propagate, and they reach what it's called critical colonization, which in essence, critical, using the word critical is enough, isn't it? And that suggests that there's so much bacteria in that wound bed that you're getting, the wound bed will stall. It'll stop healing. And so that's one of the challenges, and that's why we're cleaning wounds. We're also cleaning the wound, so we want to get rid of non-viable tissue. We want to interrupt bacterial propagation. We want to interrupt bacterial lifespan. We want to assess the wound. We want to make sure we're using an appropriate bandage. Then we want to clean the wound perimeter. And the wound perimeter is just as important as the wound itself, because the wound perimeter also offers certain things to that wound. It's where your skin is going to come from, the epithelial tissue is going to come from, to cross over that wound. As that wound fills up with granular tissue, depending on how deep it is. It may fill up with epithelial tissue, it may fill up, and that's skin, epithelial tissue is skin, or it may fill up with granular tissue, which is tissue that's sort of in the basement levels of the skin itself, where there's a lot of blood flow and what have you. And they're little bumpy red material that is building up in the wound bed, building up in the wound bed, building up in the wound bed, to where it reaches the top of that wound bed, or that it lifts the wound bed up over time, and then the epithelial tissue of the skin is allowed to cross over it. So we want to make sure that tissue, the good skin on the outside, is well cared for as well. It doesn't need to have a bunch of bacteria. It doesn't need to be having a bunch of adhesive material, tape, what have you, stuck at that perimeter. So those are kind of the reasons why we want to clean a wound. So we talked about, in loosely preparing the area, and then we went into, hand washing, and then we went into some of the reasons why we want to do wound care in the first place, why we want to clean that wound in the first place. And so now we're going to get into a portion of this study where so what we want to do now is move into the section where I'm using my buttocks model, and we'll go into that. This is a model, obviously. It has a very deep wound here. It has a wound with, covered with, eschar, which we'll get into one of these days. Stitches, a full thickness wound over here. These represent pressure ulcers that you might find on individuals that are bed bound or wheelchair bound or something along those lines. And so obviously this model is here for the purpose of educating people about pressure ulcers, pressure ulcer types, where they're located at, how deep they are, etc. And we'll get into that into another course. But for today, what we're going to discuss is how to clean a wound. And I think it's pretty easy to start, get fairly freaked out about cleaning a wound. Am I doing it right? Am I going to cause an infection? Is there an infection? Am I hurting my patient or my loved one or my friend or whomever it is that you're helping? And so we're going to kind of just go over basic principles on wound cleaning, and we'll pick out a few concerns along the way. So number one, when you're cleaning a wound, try to get the individual that you're going to be cleaning the wound with in a comfortable position. They should be in a position where, there's not going to be a lot of motion, they're comfortable, they're not in pain, and in a location where also it's comfortable for the person who's doing the wound care, and not only just comfortable, but a clean place to do the wound care. And we'll talk about that more in the video, as this video will be an insert video in multiple videos now and in the future. But we want to make sure that, again, we're in a comfortable position so we can easily get through the wound care without difficulty for either the person who's caring for the patient or the patient themselves. And certainly we don't want them moving around in the middle of it, especially if you're using a sharp instrument of some kind to where you're trying to move, non-viable tissue out of a wound bed. So that's pretty important. Let's get the patient in a comfortable position, the caregiver's in a comfortable position, something that's reproducible going forward. The second thing is, prep the area. And you can see in this video here, we have a nice cloth. It's clean. You can clean cloth with bleach in really, really hot water. You can reuse them if need be. You can put that underneath your patient and even underneath the wound of the patient, so that in your sterile field, or not really your sterile field, we'll get to the difference between a sterile field and a clean field. A sterile field is something that you're going to do in a surgical suite. Everything's going to be very, very sterile, very, very clean. People will hand you sterile instruments, and the whole process is about as clean as you can possibly get. And a clean technique, which is what we're going to be doing, what we're talking about, is more for the home environment. Obviously, you can't have a surgical team in your home, so we're going to do what's called clean technique, making things as clean as possible. So again, we're going to get a nice clean surface down. We're going to put the patient comfortably over that surface if possible. Okay, and I get that's not always possible. Sometimes people are stuck in a chair and you're kind of trying to have to, clean the wound while they're still sitting in a chair with clothing on or whatever. So do the best that you can. Nothing in life is perfect. And we're going to talk about how to clean to where you can pretty much get most of the debris out of the wound without any, it'll be better than when you found it. And that's the whole idea. So again, a nice clean area. We then want to put something down in addition. This is called a chuck. It's something that one uses in a hospital, and you slide that underneath your patient, if they're, in the bed, so that if they have an accident in bed, it helps keep the bed clean. And again, this is, comes in a somewhat clean container. You pull it out, you open it up, and of course, theoretically, what you're going to be doing is placing your instruments, such as, your gauze, your saline solution irrigation, your tweezers and scissors and stuff like that into your clean zone. You're going to put in here bandages that you're going to wind up putting on your patient, any cleaning supplies that you're going to need, an extra set of gloves here in your clean zone. And this clean zone is going to be the cleanest hot place in the house, right? You're going to have that all set up somewhere, ideally where, you're not going to, the patient's not going to be knocking into it, throwing coffee or food or blood or, feces or anything like that. We want to make sure this area is free from all of that potential, right?
You wouldn't want to, have just peeled off your lid to your gauze, for example, and then have it get soiled immediately by whatever's happening with your patient. So here is our mannequin dummy, whatever you want to call it. And, this is obviously a buttocks. There's a number of different wounds on there. We're going to turn our attention to this, I think this deep wound here. And what we want to notice about the wound is obviously it's very deep. We've got a white spot in the center. Maybe you can see it, maybe you can't. Obviously it goes all the way down to the bone. Lots of complications with this kind of a wound. The other problem that we have with our wound here is that we have a undermining area all the way around. And the camera won't be able to pick it up, but there's also a tunnel that goes off in a certain direction. We're not going to get into all of that today. It'd be a little bit too much for the scope of this video. Again, we want to just talk about how to clean a wound. So let's start with, we're cleaning the wound, but what we have is we have a bandage on there. So let's pull some bandages over. Let's see, we'll just pull out any old bandage. And the bandage, when we open a bandage, we want to open it like so, right? So we're going to peel this thing open, and we're not going to touch it, right? We don't need to touch it with our fingers. And we're going to set it down in the field where we plan to do the work. That's how you would prep the bandage prior to cleaning the wound and just having it ready for you so that you're not going back and forth digging around for stuff. You want everything in your clean field that you think that you're going to use for that wound. But since we opened this up, the reason we opened that up is we want to talk about pulling the bandage off. And a lot of times, this just happens to be an Optilock bandage. It's for a massively, heavy draining wound. I'm not necessarily endorsing Optilock. I just had this laying around and I thought I'd use it for this purpose. So here we have our bandage. It's over the wound. We're going to pretend that there's an adhesive border on this. Oftentimes when you have a wound in an area like this, you're going to need some kind of tape to keep it on your patient. Unfortunately, maintaining a bandage on the buttocks area is very, very difficult, and it's very, very challenging for many, many reasons we'll get into in later videos. But for the purpose of this video, we've got the Optilock on here. We're going to have a bandage perimeter, some kind of adhesive tape usually, that's going to hold this in place. And some of your bandages will come with tape, some come without tape. Those that come without tape, you add tape obviously. Those with the tape, they're on there. Those with tape typically tend to be a very mild adhesive, and the point of that is just to try to keep that on there without causing any trauma to the skin. Also, we're going to go over that in our later video as well. But we're going to don our gloves, and don just means putting them on. And I'll show you toward the end how we take the gloves off is also very important. These are right out of the box. This is a clean technique. We're not too concerned about bringing, the way we're going to do this, we're not too concerned about bringing any bacteria to the wound. We're more concerned about protecting ourselves. So that's why, part of the reason why we call it a clean technique. So moving back to the bandage itself, we can see that, let's just pretend that this little border here is an adhesive, and we're going to try to take that off, and we're going to try to minimize as much trauma to that, or minimize trauma to the tissue as we remove the bandage. Because if these are in place 3, 4, or 5 days, there's going to be a pretty good hold on your skin. And the last thing that you want to do is go in a hurry and pull that off and take some of the skin of your patient or your loved one with the bandage, causing a new wound. And of course, being that it's in such a location, opening them up to further infectious process, or at least the risk of an infectious process. So we're going to come along and we're going to just sort of try to tease up the edge, and we're going to tease it up just a little bit, and so we can get up underneath it a little bit, and then we're going to use our fingers and we're going to pull and anchor and pull and anchor as we gently pull off the bandage without allowing the skin to rise up on the adhesive, rise up with the bandage as you try to take it off, pulling at that skin. As we age, our skin gets thin. As we have bandages on for a prolonged period of time, our skin gets traumatized. Things build up underneath there, little red blotches and the like can build up underneath a bandage because it's been on there for so long that the skin essentially is saying, hey, I've had enough, okay? So that's that part of the deal. So now we've removed the bandage, and before we get rid of our bandage, we want to look at the bandage. How did the bandage do? Is there a, is this bandage is supposed to absorb a great deal of moisture? Did it do its job? Is the wound not putting out a lot of moisture? What does the moisture look like? Is it bloody? Is it, brown? Is it tan? Is it yellow? Look at that and sort of just make a note and put it away in your head, or, have somebody nearby maybe to take a picture of it. So you can kind of sort of get a chronology of what is your wound doing. And ideally over time it's shrinking, the wound is getting smaller in size, it's filling up, the drainage is getting less and less, maybe the drainage is no longer discolored or there's no more malodor on the bandage or in your wound bed. Those are the kind of things that we see as a progressive state. Clearly, if it's getting worse, you're getting more drainage, it's getting more bloody, it's getting discolored, it's getting yellow, green, or tan, and it smells, then we're going the other way. We're going the wrong way. So that's a little bit of a tangent, but it's important to know about what your bandage is doing. Your bandage is telling you a story. It will speak to you if you listen. So here we have our wound. We've taken off our dressing, and we're looking at our wound, and we're thinking, well, what am I going to need? It looks like it might be a little piece of tissue floating around in there. Maybe we might need some tweezers to remove that. Let's say there's a little yellow sort of sloughy kind of material over here. Well, we may want to use something like a gauze and clean that out. Or we just may want to use a saline solution. These are for IV lines, but any kind of syringe works really good. It creates a little turbidity and it helps give some lift on the material that's trying to come out of the wound. When we're doing home care and we're doing wound care at home, we're relying on a certain kind of debridement called autolytic debridement. We're not so much working on trying to do a mechanical debridement, which is with tweezers or moisture or a water pick kind of a thing. There are autolysis is when we use the body's own fluids or a gel that we would put into that wound to break up tissue that was devitalized, meaning it didn't have really good blood flow source to it. And that moisture would sort of sit in there and cleave away or sever by means of moisture the non-viable tissue, and then in theory it comes off on the bandage, or we rinse it out with our wound care cleanser, normal saline, distilled water, whatever it is that you have that you think will work. Obviously there are better choices and there are not so great choices as far as on the spectrum of being able to clean a wound and keep it from having a bacterial growth in it, overgrowth in it. And that's basically the whole idea about cleaning a wound, is to kind of see what you have each time and sort of try to mitigate any bacterial colonization in there, because if bacteria are all the way around the skin, they're on everything that we see here. There's really not so much we can do about it. We can create the best environment possible for the wound so that we can get good growth in that wound and mitigate the production of the bacteria. Okay, so that's the essential idea. Obviously, we want to remove anything that's nasty. We want to clean the wound, and then we want to find some form of dressing that goes back on that wound to pick up the moisture that might be coming out of the wound, or deliver moisture to the wound in a dry wound, and we'll get into that in future videos. And then we want to make sure that we have some kind of a dressing also that protects that wound. We're going to get into the benefits of certain types of dressings in a future video, but for today, back to cleaning. So we've taken the bandage off. We're assessing our wound. We want to look at the wound perimeter. How does that look? Is it getting white or macerated because our bandages aren't picking up the fluid and it's sitting up against the skin and causing trauma to that peri-wound area? Peri-wound area is everything around the wound bed itself. That's called our peri-wound. And our peri-wound is important because our peri-wound provides the nutrition and what have you to get this wound to contract, to get the epithelial tissue, which is skin, to move over this hole. Now, mind you, it just doesn't move over this hole and we have a hole. What we're wanting to get is granulation, which is, good blood filled tissue building up in that wound bed and building up to the surface of the skin, and therefore allowing the epithelial tissue or the skin to cross over the wound bed. So again, it's going to be very, very important to remove non-viable tissue. In the case of this wound, this would be considered 100% eschar, and it's a dry, dead tissue. In this case, it's a pressure ulcer. It can happen in many types of different ulcers. But again, it's a dry, dead tissue. Well, with this dry, dead tissue, if you were to go swimming in a pool, I use this example, you go swimming in a pool of sand, you're not going to be able to swim in sand. You're gonna dive in. You're gonna break your neck or something like that. It's so hard that it's just not conducive for swimming. And if there was a pool of water, you would dive in and you'd be able to swim around and without much difficulty. And epithelial tissue is similar in that sense that it's not going to be able to do anything really with this eschar. Now, when we're young, and we don't have any disease processes going on in our bodies. Yeah, you might have had a scab when you were a kid and the tissue grew underneath there, and one day the scab or the eschar tissue just popped off, and underneath there was good, nice, beautiful skin. And as you'll find out going forward in this wound care channel, we're dealing with chronic wounds, been there for a long time, and we have multiple disease processes that may prohibit the wound from acting the way it did when we were young. So getting back to this one here and cleaning, we're going to remove any non-viable tissue from that wound bed. It may take a course of time. This wound, such as in this one over here, here's an example where we have a yellowing material and then we have good granular tissue. So in this case, this yellow material is material that we want to remove over time. And it's devitalized tissue. It doesn't have really great blood flow supply or none at all. And if we just keep this moist with a gel of some kind, eventually it breaks down and it comes out of the wound. We're able to clean it out either through turbidity, throwing some fluid over there, or scraping it out, or using a tool of some kind to pick it out. And then of course this red tissue on the side here is an example of good granular tissue. And ultimately we want that tissue to fill this wound up. This to be removed. Also this tissue over time, if it's out there, it could start to smell or, be food for bacterial colonization, and we certainly don't want that. So it's a multiple faceted reason why we want to get that stuff out, to produce more like this. Then that fills in and then the skin can cross over. So getting back to our big wound, we're going to look at the big wound and we're going to identify things that we want to maybe pull out of that wound. We may see tissue that, it's yellow, but it's still stuck to that wound bed. And we're going to kind of leave that go for another day. We're going to continue to work on autolytic debridement, maintaining a moist wound environment, which is important for healing in all sorts of wounds, which we'll go over a study that's from the 60s on pigs, that they utilized pigs to see what would grow, basically the summary of it was they found that on these pigs that trying to heal a wound that had some moisture brought to it or had moisture controlled was one that would heal faster than our dry one in our earlier example. So again, we'll come back to this and we'll say, hey, okay, there's some yellow tissue in there. I can see it's kind of stuck there. We're not going to try to do anything with it. We're going to continue with autolysis, but we know that we want to clean the wound. When we clean the wound, we want to find out what it is that we're going to get out of that middle. So we can use a wound cleanser. There are surfactants. Wound cleansers. There are wound cleansers that bring vitamins to the wound. There are wound cleansers that are antiseptic, meaning they kill bacteria. And we have to decide, what can we afford? What do we have? And, not everybody's going to be able to have access to very expensive wound cleansers, such as the surfactant, for example. But that being said, we want to see what the wound looks like. We want to see what the wound perimeter looks like. And then we're going to go, okay, well, I'm going to go for broke here, and I'm going to take a cleanser, and I'm going to squirt, and really get the wound moistened or wet with your wound cleanser, whatever your wound cleanser is. If it is a wound cleanser that has an antiseptic in it, you can let it sit for a minute and have a little conversation. Maybe get your patient some coffee or tea in the home setting, obviously, of course. But, a little bit of a contact time ensures a little bit more death of the bacterial component of the wound. So you've done that. Then you're going to say, well, I just see that there's some little things in there. I just want to sort of see if I can pick them out. So I'm just going to just gently kind of go through here. And, there are many schools of thought on how to clean a wound. If the wound has a significant amount of just this yellow material, cleaning it out is essential. With an item such as a piece of gauze. But if your wound bed is covered with good, healthy red tissue and it's just going, gangbusters, try to refrain from scraping that material, because you could cause trauma to this tissue. This is this tissue is very sort of, I don't want to say neonatal, but it's just recently born, material, epithelial cells. And we really don't want to go in there and sort of rub it and cause bleeding and disturb that material too much. You can just clean it, with a cleanser and let it slough off a little bit, and then come in behind with, something like, this, and just give it a good little squirting. And in that case, then you'd be done with the wound cleaning, really, and you just sort of pat it dry. With a wound that's all red like this and mostly all granulated, you don't need to really use a antiseptic. Just use a saline solution. If all else is looking good, if there's no redness around the wound perimeter, no odor, no increase in drainage, and it's 100% red like that, and it looks just beautiful, no pain, etc., just clean it with some saline solution, or something along those lines. Maybe I wouldn't use tap water. I never recommend tap water, but certainly some saline solution in there, and then you can just leave the saline solution in there. You don't have to pat the wound dry in the middle. I never pat the wound dry in the middle. I always maintain some moisture in that wound. All wounds need a little bit of moisture. But if we were just to squirt that, it was 100% granular tissue, or that beautiful beefy red tissue as we like to call it, then we're just going to pat the perimeter dry and we're done. We're done with that wound. So that's the good news, right? And then you're ready for bandage selection, which we're not going to talk about bandage selection today. We just want to talk about wound cleaning today. For a dirtier wound, let's say, for example, we're back to this wound, we'll use maybe an antiseptic in there. Again, we'll let it to sit there for a little bit. And then we might want to find things, we might find things in that we want to pick out. Maybe there's a bandage that somehow got stuck in there. A certain type of bandages do get stuck in wounds. We want to pick that out. Or if there's a strand of dead material, we want that to come out. We don't want to leave material in there. I always said, whatever God gives me, I'll take out. I don't go in the wound and try to find stuff that's well connected, that looks like it has blood supply to it, and pick it out. But if it's dead, it's stringy, it's getting in the way of my cleaning, I want to cut it out. So I'll take my, this is just a little suture removal kit. I'll take my sharps, I'll open it up. This is a sterile field here, or at least a very clean one. We just want to leave them in there and put it down like so. Then we can go ahead and pull out our tweezers, and we're going to come in here, and I keep showing you the same piece of gauze. Go through the gauze. You don't need to remove or reuse gauze. It's cheap enough, but just for the sake of this video, rather than continue to go through gauze, I'm going to pretend this is a nice new clean piece. And because I did show you earlier some swiping here, so I don't want you to think that it's okay to, certainly you don't want to go from wound to wound ever, right? Ever do you want to go from wound to wound. This wound could have, Staphylococcus in it, and this one here can have Pseudomonas in it, two different kinds of bacteria. You don't want to bring your bacteria from wound to wound. That would be a big no-no. So back to this one. We find something in there. We want to go ahead and get it out. You can go ahead and brace yourself a little bit on your patients, provided they're okay with that. And then you're going to, sort of reach in there and sort of just pick at the dead material. If the dead material is stringy and long and it's still connected to the wound bed, you just come along with these guys here, your little scissors, and you pull it out and you really snip it. If you're not comfortable with that, don't bother with it. Just leave it there. In time, if we maintain a moist wound environment, that material will break down through what's called autolysis, basically a degeneration of that material because it's no longer vital. It's not getting good blood flow to it. So again, you're getting the nasty material out, and then you're going to come in behind here after you've done every imaginable, so we've talked about irrigating the material out, because bear in mind, these wounds will be producing material. There'll be, the bandages will be yucky looking. And so we know that there's bacteria buildup in here. We want to get rid of it. The big thing about bacteria is moving, the stuff up and out of the wound bed. Okay? No matter how you do it. Again, if it's a wound where we have a lot of good granular tissue, we don't want to be bringing something in there and scraping at that material. Just a little bit of moisturizer or moving fluid, such as a saline and this little microjet we call them. It's just to clean IVs out with. You just on the IV line and off things go. But the same thing would go for the wound debris. So back to this. We've decided, well, we're not really want to use our tweezers and stuff like that because we're a little nervous about it. We're just going to continue with our autolysis. Well, we can go ahead and we go back and we've sprayed the wound, and we're going to spray the wound perimeter. We want our wound perimeter to be clean too, folks, because this is just like a diving board for bacteria. Woohoo! They're going in and out of there having a great old time. So you want to set your wound perimeter up for success. So again, you decided you want to pull anything out of here. Maybe you came along and you started to use your gauze and you were sort of picking away at it, and that's okay, especially if it's over that yellow material. It's basically non-viable. There's nothing super great happening there yet, right? And then we're going to come in and we're going to hit this with our surfactant. So I'm hitting it with my surfactant. And, depending on how much of it you have, you could, literally fill that wound bed up. But a little bit's going to be fine enough. And again, it's going to get up underneath, because it's a surfactant. It'll get up underneath dead material and help pull it out. Same thing that happens with your clothes, because laundry detergent has surfactant in it also. And then once that's been done, then you can come by and you're going to irrigate it, and you'll irrigate all of that up. So let's say, and I just out of habit put this in this individual's behind crack here to keep it from running down, which would happen, right? In the case of an actual wound care, you would get some movement of the fluid in some spots that might be uncomfortable for your patient, but that's kind of the way it goes, unfortunately, and it certainly happens. So I might want to bring something more along, like a larger container of some saline solution, and just sort of pour it in here until the wound sort of just bubbles over and all that nasty stuff goes out of the wound. At that point, and so long as there's not a lot of moisture still in your wound, that might be enough. That might be enough cleaning for one day. So, bear in mind that whenever we clean our wound, the temperature of that wound drops. So we're sort of interrupting the healing process by taking the bandage off, exposing it to air, cleaning it, etc. And so that's also for another discussion, because there are other ways of sort of pushing the wound along when we do some wound care. And we'll get into the debridement concepts in future chapters here. But again, you're getting you're moving the rest of the fluid out, because you're sort of filling the wound bed up. And this is a very, deep wound. Not all wounds you'll see are going to be so deep. Let's see. So if you had to get the fluid out, I suppose you could use a brand new piece of gauze and just set it over real easily, trying to bring some of that fluid out. But again, you want to try to leave fluid in. So long as it's not swimming, leave the fluid in. It's little saline solution. It's good for that wound bed. It's good for the pH of that wound, and I like it. So now that we've got our wound cleaned, now we're going to talk about cleaning our wound perimeter. it's essential you clean your wound perimeter. You don't want to use the same gauze you'd been using. You're going to bring up a new piece of gauze, and you want to clean the wound perimeter by finding a spot and then just sort of moving the material away from that wound bed. So this way, that way, this way, whatever. We don't want to move it back into the wound bed because we've just cleaned it out. Bacteria, even though you can kill it, it needs to be physically removed from a surface. And we didn't talk about hand cleaning, but we're going to talk about hand cleaning in the first part of this video that's going to go forward. So at any rate, we want to make sure we're cleaning the wound perimeter by moving bacteria away from the wound bed. Okay, and you can go ahead and rinse this again with some saline solution. You just don't. You want to make sure that you're not letting anything go back into your beautiful wound there. Okay, so now once we've done that, we want to pat the perimeter of the wound dry. Again, we want to keep a little bit of moisture in that wound bed. We want to do moist wound healing, but we don't want it swimming. So just to reiterate, but we want to dry the wound perimeter because we want to put a bandage of some kind on, okay? And so we want this wound perimeter dry. And now what I'm going to do is I'm sort of going to pretend that we have some skin prep. Skin prep is a basically it's a skin preparatory thing that you can buy certain different kinds of skin prep. A&D ointment, something like that would work. If you had nothing else, Vaseline would work. But there's a lot of different things on the market, and what you do is you put it at the wound perimeter, just like this, all the way around that wound perimeter. The reason that we do that is because sometimes the bandages that we selected didn't work. They didn't pull enough moisture out. Maybe all of a sudden, for whatever reason, there's been an increase in moisture in that wound. And so what happens is it comes up and it goes into the dressing, and then it comes out to the sides. And so if I have a little dressing on the inside, which would be your contact layer, and then I have a secondary dressing over the top, what if the contact layer just didn't do the trick and it came up into whatever other dressing I might have and then moved off onto the sides? Well, the skin prep would help protect that skin from what we call maceration. And maceration is basically, you guessed it, tissue that's been in touch with fluid for a long period of time. Just like the wound bed, we're breaking down non-viable tissue, devitalized tissue, using moisture. That would happen also to the wound perimeter, only it's not devitalized, but it would cause maceration, or sort of like a pruning of the skin, and it would halt your wound from progressing. And that is the problem with the maceration. So a good skin protectant at the perimeter is going to be vital. You can also use different kinds of creams, just a little tiny, very, very thin sheen of a cream all the way around there. If that's all that you had, it's again going to protect the skin. There are some protectants out there that are, have what's called dimethicone in them, and they actually come along, and it's kind of like silicone on your, your windows or what have you at the house. It keeps water from penetrating, and the dimethicone is the same exact way. And there's a lot of things out there with dimethicone in them that you can put at your wound perimeter. You're going to want to make sure that that gets cleaned off. Never ever scrub the wound perimeter. Don't ever scrub your wound perimeter. Don't ever think, oh my God, my patient's really nasty, I've got to scrub my patient. You want to just, you want to treat it very, very gingerly. You don't want to rub it or break down the perimeter of the wound by use of anything like that. So you want, but again, with whatever cream you have on here, once you pull your dressing off, anchoring, well, you're still going to have that sheen. So you want to address that sheen, but you don't want to scrub that sheen. So now we have our wound pretty much clean, and then we're going to go for our bandage selection. And the bandage selection will be covered in another video going forward.
Okay, so I hope you enjoyed that. part using our buttocks mannequin. I hope you learned something about how to clean a wound. I hope that you maybe learned something about different kinds of wounds. We have this pressure ulcers on there. That I think is a good start. So we basically talked about all of the ins and outs on cleaning a wound. We want to talk about now is, of course of all, we have these gloves on, so we want to talk about how to take the gloves off. But before we do that, let's talk about what we're going to do with all the bandages. Well, we have all these bandages left. We didn't use them all, and they're very, very expensive. So we want to try to, hold on to whatever that we can so that it doesn't get soiled, destroyed, or whatever. And it doesn't drop on the floor or things like that. So you maybe get yourself some 1 gallon Ziploc baggies or something like that, and you can put bandages inside those, like type bandages, gauze in one, or whatever, tape, on and on into the baggies. Don't hold on to the baggies forever, of course, because there's potential that those baggies are going to get yucky in time, right? Everything builds up bacteria, so. Even if the whole idea about using gloves in the first place and having your sterile field, what have you, is that you don't transfer bacteria from one spot to the next. That's the key. So you want to be careful on how you manage the dressings going forward. The probability is that you're going to go through them and you'll need new ones, etc. So maybe that won't be so much of a deal. The other thing is that sometimes in the middle of your wound care, your dressings don't work, or your gloves get messy with dressing. So like if I use a Vaseline impregnated gauze, I might get some of that Vaseline on my gloves. I can go ahead and change them midway, no problem. Just make sure I have plenty of them in my sterile field. So it's okay to move into new gloves along the process. So once you got your patient all settled down, they're resting, you got a blanket on them, whatever it is, they're all covered up, the wound care's done. Now your cleanup happens. And so you want to, go ahead and put all the debris into a very specific, trash bag. You don't necessarily want to, mingle those with your home trash. So you still have your gloves on, so you're cleaning with your gloves. If you're going from one task to the next, it's okay to remove them and put on some new gloves, as I was indicating. And so let's just say that you're at the end of the task. You're either changing your gloves because you got them soiled and you want to try to do something else, or you're completely done. Your patient's resting, or your loved one's resting, and you're done with your gloves for the day. What you're going to do, you're going to take your thumb on one side, because these gloves are soiled, right? They've got bacteria from the environment on them. And so wherever you touch, you could potentially be spreading that bacteria too. The whole idea about creating a nice clean area, bringing out the chuck, maintaining a sterile field with the items that you're opening up, like the scissors that we opened up, is to keep bacteria from moving around in the wound environment and potentially getting back into the patient's wound. That's the big thing. And of course, you don't want to get it on your own stuff. You don't want to stick them in, be scratching your face with the gloves or scratching your eye with the gloves. No, you don't do any of that, because you're going to transfer bacteria from the patient to you in that case, and that's not what we want either. So to change your gloves, or to be done with your gloves for the day, you're going to hook your thumb into the base, just like that, and you'll pull it up like so, and now you got it out. Then you take this one, and you scrunch it all the way up. Scrunch it all the way up. Now you've got it in the palm, right? It's kind of like a magic show. And then you take it off like so. And now you have your gloves inside your gloves. And in this way, once you throw that away, that's not obviously not hygienic, of course, it's yucky still, but it's not going to get on anything else. And that's the whole idea.